coming to the etiology, it is multifactorial. The bottom line is there is underdevelopment of left side structures of the heart. These factors can lead to two groups. Group 1 is there is obstruction of outflow from the left ventricle. There is obstruction to left ventricular outflow tract. Your aortic valve is atretic or stenotic. The second is obstruction of flow into the left ventricle. Here you have mitral valve atresia or stenosis, or a foramen ovale which is restrictive, so no blood goes into the left ventricle. Now coming to pathophysiology, aortic valve stenosis is the most common cause for the underdevelopment of left ventricle, and this aortic valve stenosis will increase the LV afterload, which in turn causes LV hypertrophy, eventually leading to LV dilatation and decrease left ventricular contractility. Additionally, reduced blood flow through the LV inhibits the growth of ventricle, leading to ventricular hypoplasia. As a result, the pressure in the left atrium increases and there happens to be a bidirectional blood flow or flow reversal during the foramen ovale. The physiological sequelae of this reversal of shunt is decrease blood flow through the ventricle. Because the blood goes through the shunt into the atrium, there is decreased blood flow to the left ventricle. Now coming to the pathology with the inflow into the left ventricle due to mitral stenosis or mitral atresia. Here there is decreased volume which is flowing into the left ventricle. So there is decreased preload as well as pressure in the left ventricle. Any reduction of blood flow to the developing cardiac structure will lead to abnormal development that happens with this mitral atresia or mitral stenosis. Now the proportion of the blood going into systemic and pulmonary circulation depends upon two major factors, that is pulmonary vascular resistance and your systemic vascular resistance. When your pulmonary vascular resistance is going to be lower than the systemic vascular resistance, more blood goes into the pulmonary circulation and your cardiac output is bound to struggle. In other words, your systemic flow is going to come down. When your PVR is higher than the SVR, here because the PVR is high, there is going to be less flow into your pulmonary circulation and more blood goes into the systemic circulation. That means your cardiac output will be adequate at the compromise of little bit oxygen saturation. Here with PVR high, you can see the blood from PDA goes into the systemic circulation. So your systemic circulation depends upon the patency of the ductus arteriosus, also for the coronary and the cerebral circulation. Here from PDA, it goes into retrograde as well as antegrade. Retrograde, it supplies the cerebral and coronaries, and antegrade, it supplies the lower part of the body. If you look at the pressure, the right ventricle pressure is around 100/0. There is underdevelopment of the left ventricle, but the left atrial pressure is high and there is a foramen ovale which is enlarged and mixing of the blood happens here and it goes via right ventricle and PDA and goes to systemic as well as coronary and the cerebral circulation. The saturation in the PDA due to mixing of the blood, it will be around 85%.